Afternoon, everyone, and thank you for joining us for today's VIA VitaFlow in association with you live webinar. My name is Michelle Harrington. I am a registered dietitian on the Medical and Scientific Affairs team with VitaFlow North America. We are excited to bring you this educational activity and introduce our speakers. Today's topic is feeding challenges in inherited metabolic disease. What to know, what to do, when to refer. Please note this program is being recorded. Support for this presentation was provided by VitaFlow North America, a Nestle Health Science company. The views expressed herein are those of the presenters and do not necessarily represent Nestle's views. The material herein is accurate as of the date it was presented. It is for educational purposes only and is not intended as a substitute for medical advice. Please note that questions will be addressed following the presentation. However, you are welcome to submit text questions into the Q&A pane at any time during the program. Questions relating to product will not be addressed during this webinar. Feel free to contact your VitaFlow representative for product information following the program. I have the pleasure of introducing our speakers today. Rochelle Berry has worked as a nutritionist in the Children's Healthcare of Atlanta multidisciplinary feeding program for the past 15 years, most recently as a nutrition manager. She has worked with children with developmental and intellectual disabilities, as well as medically complex children for the entirety of her career. She is on the Georgia Board of Examiners of Dietitians, a position appointed by the governor. She also serves as an accreditation reviewer for the Accreditation Council for Education in Nutrition and Dietetics. Rochelle's current clinical focus is in nutrition, growth, and feeding in medically complex children. She is especially passionate about working with infants. Danielle Starrin is a metabolic dietitian in the Rare Disease Institute at Children's National Hospital in Washington, D.C. She holds a bachelor's degree in cell biology and molecular genetics and a master's degree in nutrition and food science, both from the University of Maryland, College Park. She completed her dietetic internship at the National Institutes of Health in Bethesda, Maryland. In addition to her clinical work, Danielle is an active member of GMDI. She has served on advisory boards and as a consultant for multiple rare disease companies. Danielle participates in multiple research studies on various inborn errors of metabolism. At this time, I'd like to hand it over to Danny.
Hi, everyone. I'm so excited to be here today. On this slide, you just see the disclaimer. Rochelle and I have no outside disclaimers to make. Next slide. And our learning objectives for today. I'm just going to throw these up here, but these are kind of basic. I'm hoping that you will take some of these points to the next level today. I'm thinking that we're going to really hit on them pretty hard. Next slide. Okay, so here's how it's going to work today. I'm going to talk a little bit about inborn errors of metabolism and some of the feeding challenges that I see as a metabolic dietitian. I'm then going to hand it over to Rochelle, who's going to talk all about how to address some of these. I know that in speaking with a lot of you, we feel kind of stuck because a lot of us don't have access to a feeding therapist, and we need to help our kids and even our adults as well. So hopefully today, Rochelle can give us some pointers, and I can talk a little bit about what we're seeing in my clinic, at least. So I got a little excited. I worked a little bit with Dolly too. Fun picture. Anyway, next slide. All right, so this looks a little jumbled, but let me explain to you what this is. So I thought about all the different feeding challenges that I commonly see in inborn errors of metabolism. You're going to see those on the left-hand side of the screen. And then on the right, I broke down different conditions. And I did break up some of the more mild to moderate UCDs and organic acidemias from the more severe. So here's what you're looking at. Each of these wide lines I considered a large impact. So for example, for PKU, I think that formula refusal is a really big feeding challenge. But then you see this more thin line. I think that autism and ADHD and PKU is a bit of a feeding challenge, but maybe not as severe as it might be in other conditions. So what this mess is really showing you is we have a lot of feeding challenges in these kids. None of these, these conditions only has one or two. They all have many feeding challenges. So today we're going to be very fortunate to hear Rochelle comment on a lot of these and things that we can do to help our patients. Next slide. I just want to give a brief overview, kind of taking that last slide and mixing it up a little bit the way that we want to think about it. So the condition that you're thinking about on this slide is PKU and other mild to moderate conditions. So I'm thinking PKU, MSUD, things that don't really require a tube, but they're usually on a medical formula. So our main goals for pretty much any condition, especially our proteinopathies, preventing catabolism, following a very restricted diet, regular consumption of medical formula, and we want these people to grow as typically as possible. With these goals comes a lot of challenges. And you're going to see on here shown quite a bit is power struggle, power struggle, power struggle. I think that when our kiddos do have the capacity of a typical developing child, those power struggles that you see in any other kid show up just as much as they do in inborn errors of metabolism. So preventing catabolism can cause a lot of parental anxiety. Some of that starts when they're little and then just keeps going until they get older, even though it's not necessarily one of your concerns. The family just built up that understanding of fear and anxiety. So they're force feeding their child, and then we get a power struggle. And I'm going to be really interested to hear how Rochelle talks about this, because I think that power struggle that starts even, those first bites of food and formula whenever they're little really trickles through the rest of the life of these kiddos. And that's where we're starting to see the food sneaking, and then the parents are nervous, so they just make the same thing every day. I mean, how many of us have PKU kids that literally eat like one fruit or vegetable and low protein pasta? Maybe some ranch and ketchup thrown in there, and of course some potatoes. But we get stuck on those things. Parents get stuck on those things because they feel safe. So a lot of this is the power struggle and the safety. So think about these things. Think about your patients as you're going through this. Think about the different conditions and how all of this can really be useful for so many of our patients. Great. All right.
Okay. Thank you, Danny.
Sure. So we're going to head it over to Rochelle. She's going to talk a little bit about all the things feeding. And then at the end, I'm going to wrap it up with a case study. So take it away.
Okay. Thank you, everyone, for having me. Thank you for the lovely introductions. So first, I just want to start quickly with who am I? Why am I here speaking to a bunch of metabolic dietitians? Because as I have at the bottom, I am not a metabolic dietitian. So my apologies in advance if I say things that are not exactly the right nomenclature for different things with inborn errors of metabolism. But I am a dietitian who's worked for 15 years in the field. This is my second career. My first career was in epidemiology. In nutrition, I focused my career pretty much on all things feeding. So started my career working in intensive, with most of my work being an intensive day treatment feeding program for children who have really severe feeding difficulties. And then slowly I've gone more into the outpatient world, a lot with GI and allergy, feeding tube dependence and feeding tube weaning, food selectivity, and medically and behaviorally complex children. So that might include a lot of preemies, a lot of cardiac cases, and really everything in between. And I've had a few children with inborn errors of metabolism along the way, but I always phone a friend and call the metabolic dietitian if I'm working with them. Okay, when we were working on this presentation, I said to Danny, if you can just give me kind of the basics, like what types of issues are you seeing in your population, so that I make sure that I'm going to try to address most of those. And she reviewed these as well, but A lot of them were food neophobia, how do we wean from feeding tubes, what's going on with these food jags, hunger cues, anxiety, food sneaking, which I don't know how helpful I can be with, and formula refusal, since the formula is such a crucial part of the treatment with these conditions. So first, I'm going to start with what is a feeding disorder. I think feeding disorders have become kind of a hot topic in the pediatric nutrition world. And so I want to be able to explain what they are so that you'll have a good working knowledge of what is ARFID and what is a feeding disorder and what are the differences. So first, we're going to talk about ARFID. ARFID is avoidant restrictive food intake disorder. I want to note this is a psychological or a psychiatric diagnosis. So I actually never diagnose anyone with ARFID because, well, I'm not a psychologist and I'm not a psychiatrist. I put the graphic on here because it's a psychiatric diagnosis, but it's all about food. And if you look at the diagnostic criteria for this, it has to do with nutritional indicators. So it's an eating or feeding disturbance noted by a persistent failure to meet appropriate nutritional and energy needs. So it could be significant weight loss. Well, who knows if weight loss is significant or not? I would say that's something that dietitians are uniquely trained to diagnose. Failure to achieve our growth curves or faltering growth in children. A significant nutritional deficiency. In my clinic, we also take that to mean a strong suspicion that we're on the path to a significant nutritional deficiency. We hate to wait to diagnose ARFID until we see that nutritional deficiency. So we also include kind of extreme food selectivity in that. Dependence on enteral feeding or oral nutritional supplements. That part's going to get a little tricky for you guys because the dependence on oral nutritional supplements is part of the treatment of the condition. So we wouldn't really call that ARFID. And then that marked interference with psychosocial functioning, which actually is the only part of this whole definition that is exclusively kind of related to psychology and psychiatric conditions. What is ARFID not? It's not explained by food insecurity. It's not explained by a cultural practice, like if someone is vegan or doesn't, refuses certain foods like pork. It's not explained. There's no evidence of body dysmorphia or body image concerns. So we're not talking about anorexia. We're not talking about bulimia nervosa. We're not talking about binge eating disorder. We're not talking about any of these conditions that have a description that there's a body image concern. And it's not explained by concurrent medical condition or a mental disorder. I want to be clear with that. I would say the baseline medical condition is less what this is referring to. This is more referring to, say, there's a patient who is in active cancer treatment and is losing weight or only having a taste for certain foods due to the taste differences with chemotherapy, for example. That wouldn't be ARFID because it's expected they're going to bounce back, as opposed to the child who has an inborn error of metabolism. They have a medical condition, but in this case, it doesn't quite fit the definition. They can still have ARFID. It doesn't exclude them from getting this diagnosis, if that makes sense. So I want to talk a little bit about how we can think about ARFID and what our role is in helping to prevent it and provide some treatment. So I want to talk a little bit about the learning process between the caregiver and the child and how that starts in feeding and how that can cause larger problems. So the first thing that happens is a child might be presented with a food by their parent, and they're going to display some refusal behavior. So what does that mean? I mean, we all know what that means. They're crying, they're making their head go back and forth, they're swatting, they're maybe trying to get up from the chair if they're not strapped in. They're even gagging, they're even vomiting. And so then what happens? The caregiver is becoming super stressed and they're like, okay, I'm going to take that feeding demand away. I'm not going to give that to you because that made you really upset. And then what happens there? The child learns, if I do these things, they get away from me. And so it's going to keep going. The child's going to keep refusing that bite because it's been reinforced by the removal. All they wanted was that food to be removed. So then the caregiver is also having a learning process during this. So the caregiver removes the feeding demand because you know what caregivers really don't like? Their child crying or their child gagging or their child pitching a fit. So the child stopped screaming and aggressing or whatever it was they were doing. And now the caregiver has been reinforced for removing the food. So the caregiver is going to think, I'm going to stay away from introducing food because I didn't like what happened when that occurred. And so this cycle is just going to go back and forth. It's like the caregiver is a little bit worried about the child is doing things so the caregiver removes it, and it just becomes this really dysfunctional feeding dyad. So now we're going to talk about pediatric feeding disorder. Oh, I wanted to say one more thing about that that Michelle, I apologize, I'm going back, that Michelle wanted to make sure I brought up. So with your population, you are introducing foods and medical foods, medical formulas that likely the caregiver's taste buds are not as programmed to find palatable. And so with this learning dyad, if the caregiver smells something and makes a funny noise or even gags or looks really, really worried when they're presenting this food, you can see where this falls into this feeding dyad and this behavioral reinforcement. Kids look to caregivers to know how to respond. It's kind of like when a new person walks into a room and a kid looks at their parent like, am I safe with this person? Do I go to them? Do I stay with you? Same thing happens with food. So this is, just for a starting thing with your population, making sure that the parent is presenting all of these foods that are going to be really different to them in a way that's neutral and is sending the message that they're good. Okay, so the other buzz diagnosis in the feeding disorder world is a pediatric feeding disorder. And so this is going to be impaired oral intake that is not age appropriate. So it is likely developmentally appropriate, but not age appropriate, and is associated with medical, nutritional, feeding skill, and or psychosocial dysfunction. We have an acute diagnosis and a chronic diagnosis. Acute is like 3 months. So I'd say the majority of kids we see are going to fall into that chronic duration. And those are ICD-9 codes, ICD-10 codes. So they're medical diagnoses versus the ARFID. Some examples of medical conditions that are associated with pediatric feeding disorder. This table is from the first paper that really described this with the new ICD-10 diagnosis. I'd say the ones that I see most frequently are going to be various clefts or different things that impact swallowing function. I see a lot of GI stuff. See a lot of like eosinophilic disease, see autism, but pretty much any of these things that they're really the reason causing the pediatric feeding disorder. You know, inborn error of metabolism are not on this list, but I would suggest it probably can be. It's probably just because it's a smaller population and it wasn't top of mind for the people writing this paper. And so how do ARFID and pediatric feeding disorder kind of overlap, and what are the differences? The biggest thing is that for ARFID, there are typically some psychiatric comorbidities, and I'd say anxiety is the one that I see the most, and is likely the one that you are seeing the most, is this fear associated with eating food, even when it is safe. And with pediatric feeding disorder, you're really more having those complex medical and developmental conditions that there still could be some active pain occurring or some extra protection you have to take with eating, whether it be thickening liquids or having a special diet due to allergic disease, something like that. So it's it's more of a, we need to work with you, treat something, teach you, versus get over that fear hump. Probably my best way to describe that, but I'd say these are things that people continue to debate. So I'm going to give it my best shot to tell you how I differentiate them. I would say also, as a dietitian, sometimes I don't really care. These become academic discussions. Really, we're trying to treat those kids in front of us. So the principle of kind of both of these is that the child, or maybe even the caregiver, is trying to avoid something painful, whether that's a physical pain, whether that's an anxiety or nervousness pain. They're avoiding the stimulus being food, because it is causing them some form of discomfort. Here's my little clip art. You know, it's so fancy. There's so many things that can fuel this flame. And all of those things that that Danny had noted to me are a lot of those things that fuel this flame of further trying to avoid food. So caregiver anxiety, being scared of new foods, lack of experience, developmental delay, all of these different things can just add to why a child will continuously refuse food. And so then I want to go in a different direction for just a minute, because of the world that I live in. And I want to talk about that when you see a kid with a feeding disorder. So you guys are seeing kids who have a specific medical condition. And that medical condition can explain so many reasons why a child would not be eating well, or why they would be refusing certain foods, or why they would have anxiety or obsessive compulsive behaviors related to food. But also, they could have another organic reason that they are refusing food. I'll give you an example. I have a patient who I see who has diabetes insipidus and has had a feeding tube at the first part of his life due to a lot of formula intolerance and a lot of worry about getting all the fluid in that needed to be done. And we worked with the family to do some tube weaning, and this was me and the gastroenterologist I work with, and he was doing great, and then started throwing up a lot. And I think had gotten we were so wedded to the diabetes insipidus being kind of this action for why he was having feeding difficulties. There was an appointment that we had where it suddenly hit us, like, we need to ask some other questions, because this is not following that path. in those conversations, we then learned that dad had tons of food allergies and in fact had eosinophilic esophagitis. And here we are, we work with so many kids with eosinophilic esophagitis. We had kind of forgotten. We need to be asking all those questions too about atopic history. Turned out, did a scope, his esophagus showed physical signs as well as the pathology showed eosinophilic esophagitis. So that's all to say that it is entirely possible that a child would have an inborn error of metabolism and have something else that could be contributing to their feeding problems. So when feeding issues emerge, I would say your role is to also do some typical rule outs for feeding issues. The typical rule outs that I do are asking about reflux and vomiting. If a kid's vomiting a lot, that's not typically normal. You want to figure out what's going on. Stooling patterns, I'd say constipation is the biggest one that I'm asking about, and really asking all those great questions about constipation, not just going every day. I'm sure you guys know these things, but like clogging toilets or straining or having liquid come out on the sides if we're thinking about enteroparesis. But if a child is constipated and their belly doesn't feel great, they're going to go with their comfort foods. Learning to eat new foods is going to be a lot harder. So I ask, a lot of poop questions, as all of us dietitians do. And then also I would ask about that atopic history. Again, they could have a strong family history of asthma, food allergy, and eczema. Eosinophilic esophagitis is one of the most strongly associated conditions with feeding difficulties and feeding disorder. So in my clinic, that is kind of always on the back of my mind, that thought that, like I said at the previous one, when you see a child with a feeding disorder, you always need to think about, is there an organic reason until you're proven otherwise? And then also, I didn't include it on here, but if there's any developmental delay or something like autism, those are highly associated with feeding difficulties as well. So now I'm going to talk about some interventions. Of course, this is a short talk. I could have given, a whole day workshop on this. So just a little bit of sprinkling of some things that you could be adding to your practice. So I want to introduce the concept of stimulus feeding to you, even though you probably know about stimulus feeding, even if you didn't have the exact words to say that. It's gradually increasing exposure to a fear-evoking stimulus. So I used a spider on here because a lot of people are scared of spiders, and we all think about basic phobia treatment would be maybe first you would look at a picture of a spider, and then maybe you would look at the spider behind glass. I mean, none of us are really touching spiders, but we slowly get to the point where you can see a spider without sweating or becoming physically having a panic attack. It's the same thing that we're going to be recommending with food and different feeding challenges. And I want to note that the stimulus feeding might be for the patient or it might be for the caregiver. For the patient, it could be for the child who has food selectivity and food neophobia and is scared to eat new foods. And I'm going to talk to you about how to do that. For the caregiver, it could be for the food, say the diet's been liberalized based on some of the treatments that I was hearing about, that you're wanting them to be more liberal, they're scared to be. So you might have to give a feeding plan for the caregivers to help bring down their anxiety. Because again, we're always going back to that caregiver-child dyad of feeding. So stimulus feeding is very good in dietary variety. I know that yogurt and peanut butter are high protein foods, but please just roll with me on this. So this is showing you examples of different types of foods. Say you're working on a kid to eat a whole sandwich. You might start with a quarter of the sandwich, and that's all you would put on the plate. Because that's one thing to know. whatever food a caregiver puts on the plate, that child is going to think, I'm expected to eat all of that. So one way that we use fading is we bring that expectation way down to make it achievable for the child. That's maybe increasing the number of spoonfuls or increasing the number of pieces, like with the strawberry, cutting things in fourth. One analogy that some of the psychologists I use have told me that really stuck well with me is a food like mayonnaise. Most of us don't eat mayonnaise off a spoon, and some people are even like a little disgusted by mayonnaise. So if someone took a whole spoon of mayonnaise and put it up to your mouth, that would feel really weird, like kind of gaggy to eat it. But if they just dipped it, if they just took the little tip of the spoon and put it in the mayonnaise and expected you to lick it off, you could probably do that. You probably wouldn't gag. And you could probably slowly increase it so you were like desensitized to the kind of grossness of eating a whole spoon of mayonnaise. So this is the same exact concept. So with your patients, if there's a food that you're trying to get the child to eat, start way small. And I have some other pictures that can demonstrate that for you. And sometimes I say, do the size of your pinky fingernail, anything, and then you can get some momentum from there. But remember, whatever we put in front of the child is what they think they have to eat, and they're going to have really strong behaviors to not eat that food. And this is an example of if you're needing to wean from some oral food supplement or even from some tube, is that you slowly are increasing it and then slowly decreasing the amount of drink. So just giving a plan that keeps things equaled out. Fading, this concept of fading can be used in a lot of things. This can also be used in formula refusal. One idea is to mix the formula with the preferred drink or juice. I have a feeling you guys are already probably recommending this, so I hope I'm not getting a big eye roll on the other side, and slowly fading out that preferred drink. Another idea is more in line of what I was talking about before, is that you say, okay, we're just going to put a ½ ounce in there, and you just have to finish that ½ ounce. And then after like 2-3 days, they're successful drinking in a ½ ounce, okay, an ounce. I know it's not the amount recommended, but it's better than not drinking any of it all, and slowly working it up so it becomes part of the child's repertoire as well. Again. Okay, food neophobia, what is it? It is the tendency to reject or be reluctant to try new and unfamiliar foods. It is a very normal part of child development for any of us who have been kids, had kids, seen kids. It also makes all the sense in the world that it is magnified in conditions that restrict foods. I think when I was thinking about planning this talk for this population, what came to my mind the most was the kids I see with food allergy, who have been told their whole lives that not to eat a food, really scared for it, because in food allergy, you're going to have this very strong reaction that sometimes includes stopping breathing. So they're scared to try anything because they, in their brain, can't figure out what's safe and what's not. So that occurs strongly in that population. I've seen it some with type 1 diabetes, especially I had a child who had type 1 diabetes and autism. Heard the doctor say to limit carbs. He just stopped eating and refused to eat a carb. And that was kind of that food neophobia. He was really scared of what would happen to him if he ate a food that had carbohydrates. Use of choice can be very good for food neophobia, and then we can talk about how we bring fading into that. So first, we're going to identify what food groups to be targeted. We're going to try to make it as simple as possible. This is where you as the dietitian might say, the kid's actually doing fine with fruits right now. We're going to just focus on a vegetable. or, I really need them getting some sort of carbohydrate source on board. But I think that's where you're going to lead it as the dietitian, and then figure out what type of choice you're going to give the child based on their nutritional needs. You're going to work with the child and the caregiver to determine foods to taste in a taste test. A taste test is a form of choice. Conduct the taste test. Within that, we might get to pick different sizes. Any area that you can give a child a choice is a good one, because it helps them feel less nervous and more in control. And then they can rank order the food. Sometimes that's just fun to say, I want to do this first, this second, this third. I often just go by food group, where I pick all of the foods currently accepted. Yours might look a little bit different based on what the nutrition prescription is. And I also look at foods previously accepted. If a kid has recently dropped a bunch of foods, or over a period of a year or so has dropped a bunch of foods, working with those foods that are previously accepted from a behavioral standpoint are going to be your best bet. And then give as much choice as you can possibly give. So you might say, okay, we need more fruits, we need more vegetables, and we need more dairy. It's probably going to be non-cow's milk dairy for you, I'm assuming, or maybe not. And then say they pick fruit. Okay, here's 6 different fruits. Which one do you want to try? Every layer that you can add in choice is going to increase the likelihood that that child feels in control. You can also pick the size. Do you want to eat a whole green bean, or you just want to eat a small green bean? Do you want to eat a few pieces of a small green bean? Things like this. And then last thought on this, don't let perfect be the enemy of good. You can get to a point where you say, this is good enough. I'm not nutritionally worried about them anymore. They've got 2 fruits, 2 vegetables. They eat them every day. We're moving on for right now to the next thing. I tried to think of some different ways choice could be used. Food sneaking is a hard one, and I don't think I'm the right person that's going to be able to solve that for you. But one thing I did think of for that was asking a child, how would you like your day to look? At what times do you want to eat food, and kind of writing it out for them. For foods to eat prior to bed, for kids, I understand, who have fasting precautions, it becomes a little bit of a battle as you're getting them to go to bed when you really need them to eat. The choice could be, we have this food, or this food. Which one are you going to eat? And even writing it out so the child knows what to expect. Kids like to know what to expect when, especially a child who is on the more anxious side, and some of their food stuff is likely related to their anxiety. Having a list, having a schedule with times, including their other fun activities they're doing in between, can be very useful. I have some families who will put up schedules on the wall, show them what the time looks like, of when they're going to be trying their new foods, or when they get to have their preferred foods. For food JAGs, I was thinking it could be something like, okay, you get to eat this 5 times per week. Pick when during the week you want to eat this, and that's the only time you can eat that food. So anything that is going to help the child know that there's limits, and that also gives the parents kind of those limits to lean on. For tube weaning and developmental delay, I understand this is a concern in the population as well. I think these are the circumstances where working with a speech pathologist, or I'm going to give you some basics. Not everyone has a speech pathologist on speed dial to understand skill, and then consider altering the texture of foods with the child to build their endurance. The kids that you're seeing and the kids that I see are often missing these windows of basic feeding development. So when that occurs, so when a child's like 6 months or 7 months and they first start getting some foods they can munch, they're going to have this like basic munching pattern, and they have these reflexes. If you think about it, it's pretty amazing that teaches us how to eat. You don't have to teach a child how to chew. You don't have to teach a child how to detect a food. Is it smooth enough that I can swallow it now without choking? But when they miss those key milestones in development, which might occur because of a medical necessity kind of trumping the natural feeding progression, it is something we're going to have to teach. So for some of your kids, if you're finding that you're ready to introduce foods, they've been highly formula dependent, or the caregivers have been scared to introduce foods, and here they are already 3 years old, they're not going to be able to move straight to table texture. You're going to still need to go through all of these food textures. You're still going to need to go through puree, mashed food, etc. And then kind of one of the last things I want to say before we move to the case study is don't forget your basics as a dietitian. You know, for those of us who work with medically complex kids, we all do, there can be this tendency for these children to be seen as kind of sick kids by their family. And then they forget their basic rules that they might have for all their other kids. And so we have all these amazing medical advances so that these children can lead incredibly typical and productive lives. So we want to make sure that we're still giving the instruction about regulating the meal pattern and limiting meal time to 30 minutes and offering foods from as many food groups as possible and making sure that we're having the variety. And those are things that are the basics of pediatric dietitian that apply to, I haven't found a population that they don't apply to. So when to refer, I'd say when to refer is when between their condition and their feeding disorder and the growth and nutrition needs, you cannot find any commonality in the middle that makes you feel like you can keep their nutrition moving in the right direction. That would be when you would want to think about referring out to some feeding therapy. Depending on the area of the country you live, I'd say there's speech pathologists who do feeding therapy, occupational therapists, behavioral psychologists, and some other psychologists are also picking it up as well. So I went through a lot in a short period of time, but I wanted to make sure that we got back to the case study.
Great. Rochelle, amazing. I've been sitting here taking notes for myself, despite having worked with you for, a couple months on this talk. I still got many things that I'm going to take back with me. So thank you so much for that. Guys, I think that we're all pretty lucky to have not only a feeding specialist, but she's also a dietitian. So she just gets our world a little bit better. So Rochelle, thank you so much. So now that we've learned a few different strategies, I'm going to present a case study for a child who has propionic acidemia who got a liver transplant. And you're going to see where maybe Rochelle could have helped me with a few things for how to give this child a better feeding experience, but we don't know what we don't know. So now let's dive in. Next slide, please. Okay, I'm going to just go very gently over what propionic acidemia is, because that's not really the point of this talk. So propionic acidemia is a proteinopathy that involves disordered metabolism of the vomit. So valine, isoleucine, threonine, methionine, and odd chain fats. When these build up, we get a buildup of propionic acid, which can lead to metabolic decompensation, stroke, and even death. So very quick of what that is. Next slide. And I shamelessly stole both that last slide figure, as well as these points from the CERN PROP guidelines and toolkit. So this is verbatim what we all find on CERN from that toolkit, which we all know is so useful. So the nutrition goals of PA is to reduce those offending metabolites, avoid over-restricting intact dietary protein. And this is a little different from the case that I'm going to present. The child is a bit older now. So some of these guidelines were a little bit different back then. Maintaining catabolism, promote adequate protein synthesis, meeting nutrition requirements, and promoting normal growth and biochemical and nutritional status wherever possible. Next. Okay, so let me introduce you to this little girl. She was born a full-term infant, no problems at birth, and she was diagnosed on newborn screen with propionic acidemia. So she was asymptomatic at diagnosis, which kind of led our team to use this term that we really do not use anymore with PA. We labeled her as more mild. Back then, my clinic was using a lot of medical food for PA and MMA. Now we pretty much never do. So just to give you a glimpse of what her diet was like, she was on a standard infant formula, 50-50 protein of standard infant formula and an infant PA MMA medical formula. We also threw in a carbohydrate and fat modular. We know that kids with PA struggle to gain weight sometimes and struggle with those satiety cues. This mother would have breastfed, but at the time our clinic did not allow breastfeeding these patients. And now we do that very differently. And we allow even some feeding at the breast whenever possible. So this kiddo had a bit of a different start than the way we're doing things now. Everything was going pretty smoothly. We all know that wonderful honeymoon period. And then at around 10 months, things kind of started to break down. Motor delays were noted. She was being admitted more frequently. And as far as feeding skills, she was just tasting purees. All of her formula was coming through a bottle, and she would take like just a little bit of puree. Fast forward to about age 2, we had more admissions. She started to develop frequent pancreatitis, and she started losing weight, mostly because she stopped wanting to take the bottle by mouth as much. So she's 2 years old. She still was barely getting any solid food, just some purees, losing weight, but she wouldn't be seen by a feeding specialist or a speech pathologist until she could sit up. So this family didn't have the means to get outside therapies. They were relying on the infants and toddlers program. And this is what she was given, not much. So at around age, about at age 1, we transitioned her from an infant formula to a standard ready to feed pediatric formula, again, keeping in that PA and MMA medical food and carbohydrate and fat modular. So she's got her G-tube, but she was still taking some formula by mouth. And then she's, a little over 2.5, and she stops taking the bottle. So with time, as you see, like her feeding skills are just getting worse and worse and worse. She was taking purees, but only if her mom fed her. And she would spit out any other texture. She started to gain a little bit too much weight. We were feeding her through the tube. She was gaining too much weight. So we tried to decrease her, the amount of calories in her formula, which, as we all know with PA, once they get overweight, it's really hard to bring them back down because any catabolism gets them back into our hospitals. So we couldn't really keep her formula calories down as far as we would like to kind of maintain a more typical weight gain because, sorry, I lost my train of thought there for a minute. Going back, we also know that when these kiddos get admitted, we're pumping them full of dextrose. And so they're gaining all that weight from their admission. And then we send them home and we can't decrease their calories because of catabolism. And we just get into this like cycle of making overweight kids by no fault of their own, of course. She was nonverbal. She was getting some speech around her 3rd birthday, but still wasn't speaking. And, just really challenging for the family to see this like steady decline of her skills. Of course, we all know that underlying, she was probably having, frequent hits of elevated ammonias to the brain, which wasn't helping her development at all. So at about 3 years and 9 months, she was eating some fork mashed foods, very soft foods that are just a little bit mashed, but she still wouldn't eat at school. Still getting tube feeds, not drinking her formula by mouth, which, let's give her some credit. We've all tasted these infant formulas and they're not as palatable as we might like. So, she'd been on it since birth, but she did start to, refuse to take that. Next slide. So when she was 4 years and 7 months old, we were able to get her a new liver. So she went through a liver transplant. Here we see it. Let's look at this as like the data point of the day that she gets her liver transplant, essentially. So she was overweight. She was getting about 87% of her calories from formula through the tube. She was eating some soft foods, but not many, essentially nonverbal as well. Fast forward just like nearly 6 months, and we see this huge change post-transplant, which I'm hoping that you all have seen this as well with your PA and MMA kiddos after transplant. She started eating hard, crunchy foods, crackers and cookies, which, let's think a little bit about what Rachel was saying about family stress and just like wanting to do the right thing for their kid. They just want to feed their kid. And so she was really focusing on these really highly palatable foods and not so much on more nutrient dense foods that we might like. But from a feeding development perspective, she was getting new textures in, which was exciting. We were able to decrease her formula to about 50% of her calories. Some of that was going through the tube and some of it was by mouth. At this point, though, the formula taste had changed a bit because we were able to take out that PA MMA medical formula and she was just on a standard pediatric ready-to-feed formula. Our diet restrictions from our clinic is post-transplant. These kiddos are maintained on a vegetarian diet. Our goal is about the RDA of protein, but for the most part, we're not making families count, especially families who have low medical literacy like this one. We just kind of set some guideposts for them. All right, so now she's about 5.5 and she gets an autism diagnosis. Honestly, no surprise to any of us who worked with this patient population. But her motor skills are improving. She's getting more words and she's slowly self-weaning from her formula. So we're, kind of seeing some change in her weight. And I'm going to show you a growth chart in a minute. Around 7 years, her weight plateaued though. And she was getting some formula overnight through a G-tube, about 20% of her calories. But again, the variety of the food she was taking by mouth was increasing. At this point, she's fully bilingual. So the family spoke Spanish at home. She spoke English at school and could easily switch between both languages, which is pretty remarkable going from nonverbal only, a few years before. Then her weight gain didn't keep going as well as we thought. But we worked on it. So we increased formula a little bit more. Her speech improved more. And now, fully post-transplant, she's on a vegetarian diet. She's self-weaned from formula, and she's working on some of that food neophobia. Let's just dive into this next slide, Rachel, so I can just hit on a few more points. Okay, so let's talk about some of the challenges that we faced. Up here, you see her birth to 2 growth chart. We don't need to see the whole thing. You just need to see this part. As you see, she just plummeted in weight from 18 to 24 months. And that's when we were seeing those frequent bouts of pancreatitis. So we're kind of starting down here. She's refusing the bottle. We're getting a G-tube at around age 2, but we're getting a lot of admissions. So even though I stretched this growth chart out a little bit so that I can put in the data, but if you saw it more scrunched up, you'd see that spike in the percentile of her weight. Not feeding at school. This star right here represents her liver transplant. So as you see, weight was just going up and up and up. We're losing skills. Transplant. Weight plateaus. She's eating more foods, but weight is plateauing. We start to increase the formula a little bit. I should add some of these data points you don't see here. In our facility, our liver transplants are done at an outside hospital. We do them at Georgetown. So I don't necessarily have all the appointment data from her Georgetown appointments in my system. So I have notes that tell me a few different points, but I don't necessarily have all of her weight. So around age 8 was whenever we went back up on the formula, and she just started to not really take it as much, but her growth has maintained itself. So we've been pretty pleased with her. All right. I talked really fast to try and get through this. Rachel, any points you want to add about this little girl before I jump to the next slide?
There's like kind of two things came to mind. One was the point where you're trying to figure out like the balance between her tube feedings and her oral feedings, and she's gaining excessive weight, which sounds like is a problem in this population. I had a child, I think it was like a gym storage, she said, I can't completely remember, who had a similar issue where she was gaining a lot of weight because of all the tube feedings they had to do. And so I worked with mom to really limit what the size of her non-formula meals would be, so that one, mom wouldn't be overstressed by how much she needed to get her in the meal, and the child could see it was a small amount, and it gave us more ability to work on new foods because so much of the calories were coming from formula because that was the medical necessity. So looking at caloric needs and kind of putting limits, and that gave us some more freedom to work on other things because we were really looking at food more as like enhancing life versus meeting all of our nutritional needs. And I think it helped to better level set the feeding relationship and bring the child and the caregiver anxiety down. So that's just one thought. And then with the second part, I think really sorting out with the caregivers, like who's having more of the issues, the parent or the child, and making sure that you're giving maybe each of them a plan. Like, okay, caregiver, your plan is that you're going to offer a fruit at every meal or whatever it might be, like as opposed to offering the crackers or whatever. And then child going through some of those choices. So those are kind of the two things that jumped out of me when I was
That's really great, your mention of like starting with smaller portions, even if they're getting in too many calories, because I would be thinking, oh, I want to give more food so I can decrease that formula, but slowing down and just taking it more stepwise, I think is a really good point.
Because actually we're going to be so scared, like even we as clinicians are going to be scared to cut down on the formula. So let's just acknowledge that and just focus on like getting back to basics with that feeding relationship.
That's great. Yeah. All right, let's go to my next slide, but I promise folks we're done. So we're going to save some time for questions. This is not the baby that I'm speaking of. This is one of my MMA babies who we all have those certain patients that just touch our hearts, and that's this one in particular. So here we see him whenever he was still in his first admission with an NG feed. Eventually he got a G tube, and this is him post-transplant. You see his beautiful little liver, giant liver scar that these tiny babies get. He has a port, he has a feeding tube. So that's just showing all the challenges that these kiddos are really facing. It's not just dietary, it's also physical. Being able to sit up after you have a huge, I mean, look at how big that incision is on this little tummy. It's hard, it takes some time. So working on those skills, thinking beyond just the motor, or just thinking beyond the food and also the motor challenges. I'm gonna stop right here and we can go to our last question slide. All these slides will be available, I believe. So if you have questions about any of this, let me know, but I wanna hit your questions. So bring it to us. What you got, Michelle?
Thank you both. We actually do have questions. So please, people, put them in the questions pane. Okay, Megan would like to know, and I believe this is to Rochelle, do you give parents any guidance on an expected window time-wise in terms of expecting to see an improvement in food acceptance?
So a phrase that I frequently use is that the child's going to tell us how fast they can go. And so we're going to bring down the what we're expecting of the child, as I was discussing with that fading. So we're going to call acceptance maybe allowing 1P to be on the plate. And then when the child is ready to have 2Ps on the plate or eat 2Ps, then we'll move up to 3Ps. And so getting a different view of acceptance. Acceptance isn't they go to grandma's house, they sit nicely and they eat everything that's presented. too much too fast. But figuring out, I think our job as clinicians is to bring down what we're expecting of the kids to a point that they can succeed and get momentum, and explain to the parent, we're going to take this all as wins. And so also explaining, we might not get to a child who eats everything they want to eat. We want them to eat. They are not robots, but we have to decide our point where we're comfortable enough and what are our primary goals. So I'd say usually we can make progress quickly, as long as we are maybe considering progress sitting and taking 5 tip dip bites of applesauce. We have to accept that that's progress.
So Rochelle, with that, would you be offering that single pea every single day?
Yeah, if that's what everyone's agreed on, I would
Okay.
offer, like, and so if you're eating the pea, I usually do like a 3-day rule. If we've got 3 days where they eat the pea, then we're gonna give them 2 peas. Because what we don't want to do is, you ate a pea, you get another pea. Then you're just punishing them. They ate, so you're punishing them by giving them more. Their goal is to stop getting them. So I try to give parents, I'll write it out, like with 3 days of acceptance, then we double it. And so that they have a plan, they feel their anxiety's down because they've been given a really clear plan, and the kid has a plan. And so that's my recommendation.
Thank you. Okay, I'm going to take 1 or 2 more questions just in the sake of time. And this question could be for both. Lindsay is asking, well, first of all, wonderful presentation. For many of our kids, they're nutritionally meeting needs, since a lot of their nutrition is coming from formulas, but they accept very few foods. For those type of patients, how picky is too picky? At what point would you recommend referring out? Is it a certain number of accepted foods, perceived social impact by the parents?
So
So much of this, I think, would be case to case. And I'm picturing kind of different categories of patients. You know, when we're talking about our PKUs and our more mild to moderate proteinopathies, I think the approach would be very different than a more severe condition where they're only eating, 50 calories a day anyhow. But Rochelle, what do you think?
I would also, that's where I would look about how much it's impacting the family and how strong the response is. If the child just sits nicely and enjoys being at dinner with the family, all the things, then and we've kind of all decided that's not what we're worrying about right now with the child, then that's okay. If the child insists that the family eat in a different room than them, or refuses to have anyone else have those foods, and it's becoming more psychosocially inappropriate and frustrating, then I would say maybe we should initiate therapy. And then if we got to a point where we feel like they're just like, we have them good enough, but if anything drops in this situation, we're like really in a bad place nutritionally. No one feels good when we're there. So starting to work on a plan before we're panicked is always a good thing.
Right. Okay, let's just take 1 more question. This one's for Danny. Mazamila is asking, for PA breastfeeding, in case it is expressed milk, what do you do? If otherwise, how do you decide when to feed along with a PA feeding regime?
Okay. Trying to kind of figure out what we're going for there. So let me just talk a little bit about PA and breastfeeding. When feeding at the breast, you have to consider many things. You have to consider, the mother's desire. You have to consider the experience of the mother. I find that first time lactating mothers do not do very well at letting these babies feed at the breast, because there's too much variability in getting that feeding relationship established. So you have to consider the mother's production, so many things, and also the growth of the baby. So really what we focus on when we're using breast milk is the growth of the baby. It might result in more checks with the clinic. It might result in more weight checks. But if those babies are growing, then we do allow breast milk and feeding at the breast whenever possible. I hope that answered your question, but feel free to chime in if not, and I can type that in.
Okay. Don't see anything else from Mazamila. So this time, I just want to say thank you to both of our presenters. This was such an excellent talk. I learned a lot. I also want to thank our audience. Thank you for joining us. Thank you for your participation. All attendees will be receiving a PDF of the slides for the presentation, as well as your CPEU certificate. And I just wanted to say, on behalf of VitaFlow, in association with you, we hope that you found this information valuable to your practice and that you have a wonderful weekend. Thank you.